welcome to the class. So that today's topic of discussion is the management of third and fourth degree perineal tears. It is a Green Top Guideline number 29. It is published in June 2015. Now we will see only the executive summary of these particular guidelines. So classification terminology. If there is any doubt about the degree of third degree tear, it is advisable to classify it to the higher degree rather than lower degree. Is it clear now what I have already mentioned? If you have a doubt of third degree tear, then it is advisable to classify it to the higher degree than the
Yes,
lower
sir.
degree. Okay.
To
Risk,
overestimate it.
yes. Risk factors for obstetric anal sphincter injuries. Risk factors, first thing, risk factors do not allow the accurate prediction of OSS. There are known risk factors, but it does not mean you will accurate predict that this patient is prone for the development of OSS. Okay. Prevention, what you can do to prevent: one is a protective effect of episiotomy is conflicting. Okay. Second, mediolateral episiotomy should be considered in instrumental delivery. So when you are performing a instrumental delivery, you go for mediolateral episiotomy. However, protective effect of episiotomy, routine episiotomy, is conflicting in preventing the perineal tears. Okay. Where episiotomy is indicated, the mediolateral technique is recommended. The careful attention to ensure that the angle is 60 degree away from the midline when the perineum is distended. This is also SBA. What should be the angle? It should be 60 degrees away from the midline when the perineum is distended. Okay. Perineal protection at the crowning can also be protective, and warm compression during the second stage of the labor reduces the risk of OSS. Okay, so these are the protective factors. When you are giving the first thing, episiotomy is selective, but when you are giving, you should give it at 60 degree on a distended perineum. Second, perineal protection at crowning, and third is a warm compression. Nowadays, this warm compression, they say that is more protective. Okay. All women having a vaginal delivery at risk of sustaining OSS or isolated rectal buttonhole tears. They should therefore be examined systematically, including digital rectal examination, to assess the severity of the damage, particularly prior to suturing. Now, how the repair of OSS? Again, here there are questions. Every subtopic is a question from here onwards. Repair of third degree and fourth degree tears to be done by an appropriately trained clinician or by a trainee under supervision. Repair should take place in an operating theater under regional or general anesthesia with good lighting and with appropriate instruments. So sometimes they may ask you a simple question such and such findings the patient has delivered, and on examination it is found that there is a third degree or fourth degree tear. Then next step will be shift to the there may be option that suture in the labor ward, suture. So operation theater under regional or general anesthesia is the place, along with good lighting and appropriate instrument, and by the trained person, okay, who is trained in treating these tears. Okay. If there is excessive bleeding, a vaginal pack should be inserted and women should be taken to theater as soon as possible. Repair of OSS in the delivery room may be performed in certain circumstances after discussion with the senior obstetrician. So primarily it is the operation theater. Okay. And if there is excessive bleeding, you can pack and then you shift the patient to theater. Figure of 8 sutures should be avoided because they are hemostatic in nature and may cause tissue ischemia. Okay. So no figure of 8 stitches. A rectal examination should be performed after the repair to ensure that sutures have not been inadvertently inserted through anorectal mucosa. If the suture is identified, it should be removed. Techniques for repair of the anorectal mucosa. Torn anorectal mucosa should be repaired with sutures using either continuous or interrupted technique. So when the anorectal mucosa is there, you can suture it by continuous or interrupted sutures. Okay. Technique for repair of internal anal sphincter. Okay. Now when you internal anal sphincter is damaged, it can be repaired with interrupted or mattress sutures without any attempt to overlap the IS. So internal anal sphincter, there is no overlapping. Okay, these are all SBAs. How it should be sutured? It can be sutured by interrupted or mattress suture without any attempt to overlap. Okay. Now, if there is external anal sphincter, then you have to see whether it is a full thickness or partial thickness. If it is a full thickness external anal sphincter tear, either an overlapping or end-to-end anastomosis method can be used with equivalent outcome. So, if you have a full thickness but external anal sphincter injury, you can do either overlapping or end to end. But if it is a partial thickness, that is 3A or 3B tiers, then only end to end technique is advised. So partial thickness, go for end to end. Full thickness, you can go for end to end as well as overlapping. If it is an internal anal sphincter, there is no overlapping. You can use either interrupted or the mattress sutures. Okay. Then which suture material? Okay, they give always combinations of this. Okay, continuous, interrupted, with this suture, with this type of suture. Okay, so for repair of anorectal mucosa, 30 polyglactin, that is 30 Vicryl, what we call it, as it may cause less irritation and discomfort than PDS sutures. Okay, for anorectal mucosa, always 30 polyglactin, that is Vicryl. Okay, repair of external anal sphincter and or internal anal sphincter muscle, you go for monofilament sutures such as 30 PDS or modern braided sutures such as 20 polyglactin. So here, if you are dealing with sphincter, then it is 30 PDS is used. If you are suturing the anorectal mucosa, it is 30 polyglactin, that is Vicryl is used. If you are suturing the sphincter, either internal or then external, then go for 30 PDS. And if you are using Vicryl, then it is a 20 polyglactin. Okay, 20 polyglactin can be used with equivalent outcomes. When obstetric anal sphincter injuries are performed, burying of surgical knots beneath the superficial perineal muscles is recommended to reduce the risk of knot and suture migration to the skin. Now, surgical competence. Who should repair these obstetric anal sphincter injuries? Sphincter repair should be performed by appropriately trained practitioners. Formal training in anal sphincter repair technique should be an essential component of obstetric training. Post-operative management. What you will do post-operatively? You will give broad spectrum antibiotic to reduce the risk of post-operative infections and wound adhesions. Then use of post-operative laxatives is recommended to reduce the risk of wound adhesions. Third, you will give bulking agents will not be given. Okay, you will give laxatives, but the bulking agent should not be given routinely with the laxatives. Okay, local protocols for use of antibiotics, laxatives, examination, follow-up of women with obstetrical anal sphincter repair. So you need to have a local protocol of how you are going to follow these particular cases, and you need to teach these patients, educate these patients accordingly. Then physiotherapy following repair of OASIS could be beneficial. Okay. Now the follow-up. Review at convenient time around 6 to 8, 12 weeks postpartum. That is in the perineal clinic we have seen. Review should be by the clinician with a special interest in the obstetric anal sphincter injury. If a woman is experiencing incontinence or pain at follow-up, referral to specialist gynecologist or colorectal surgeon should be considered. So when this lady comes for follow-up and having incontinence or pain at follow-up, you have to refer these patients to specialist gynecologist or colorectal surgeon. Prognosis. Women should be advised that 60 to 80%, that means 6 or 8 out of 10 women are asymptomatic at 12 months following delivery and external anal sphincter repair. Okay, so at 12 months, almost 60 to 80% patients will be asymptomatic. Okay, now see the what does the guidelines say about the future deliveries. Okay, if there is a history of obstetric anal sphincter injury in a previous pregnancy, counsel about the mode of delivery and document in the notes. Role of prophylactic episiotomy in subsequent pregnancies is not known. Okay, prophylactic episiotomy role is not known. This should be only be performed if it is clinically indicated. All women who have sustained obstetric anal sphincter injury in a previous pregnancy and who are symptomatic or have abnormal anal ultrasound, endoanal ultrasonography, and or manometry should be counseled regarding the option of elective LSCS. Is it clear, this particular line?
Yes, sir.
Okay. So the last is a risk management. So you need to have a clear protocol for the management of obstetric anal sphincter injuries, document anatomical structure involved, method of repair, suture material use. So when you are documenting, you have to mention what was exactly the tear, anatomical structure, what was involved, how it is sutured, what type of sutures were taken, and what type of suture material is used. And you have to debrief the patient and advise the follow-up. Okay, so that finishes the executive summary of the guidelines on the third and fourth degree perineal tears. Thank you.